Okay, good morning. Thanks to Ben and the Chicago team for putting this all together. So we're going to talk about now in the setting of PAO for borderline, when do we need the scope, indications, and outcomes for isolated PAO and borderline, standard disclosures. So we'll hit on the outcomes in borderline. Does hip arthroscopy, the addition of hip arthroscopy make a difference? This is an area where we do have some evidence now compared to where we were 5 years ago. So what can we learn from the PAO RCT? Are there negatives of arthroscopy? The addition to PAO are important to consider, specifically adhesions, and then when does it make sense in the borderline hip? So we're in an era of sort of this paradox, increasing use of hip arthroscopy in the setting of PAO, but evolving evidence that probably says in most cases it may not be necessary. The long-term outcomes of PAO probably really rely on cartilage health, less so on pathology of the labrum. So are there negatives to hip arthroscopy with the PAO? So here's a case done elsewhere. Relatively mild dysplasia, pretty well done PAO, everything's healed. But this patient had other things going on. So they had a staged hip scope PAO, 5 days apart, 3 anchor repair, arthroscopic osteoplasty, capsular plication, and here she is 6 months later, worse than pre-op. So the PAO, we would think, is not the issue here. It's the hip arthroscopy, and she has extensive scar tissue. The MRI shows all the damage going on this hip, and we may be going backwards in some cases if we don't do the arthroscopy appropriately. So what are the positives of hip arthroscopy? Hopefully we can decrease the rate of residual symptomatic labral tears. The negatives of arthroscopy at the same time, we're creating a rate of symptomatic labral adhesions that is a real thing. So you need to be gaining more from option 1 than you're losing from option 2. If we look to the literature, most studies would say hip arthroscopy after PAO around 3 to 10%, some even 0. One study out there as high as 27, but maybe not reproduced in other centers. And certainly some bias in our literature, as some of these patients may go elsewhere, so some of our studies might not adequately assess that. The highest rate in the literature comes from Denmark, 27% rate of hip arthroscopy after PAO, and they found in the borderline hip it was even higher, 2.8 times odds ratio. So many of their borderline hips they went back on. It's very interesting to understand why this is and maybe why we haven't seen this in other areas in the literature. So what are the outcomes of isolated PAO in borderline? So we published this in JBJS a few years back that the outcomes of PAO in borderline can be very, very good, maybe the best outcomes of PAO surgery because the socket is very close to normal, and these people after healing can have a very normal anatomy. So this was our study, almost 200 hips. At this time, 70% of hips with borderline dysplasia, we're having arthroscopy compared to 40% in classic dysplasia, and high rates of clinical success around 90%, that not only equivalent to kind of FAI work, probably better than what we see in FAI with low rates of revision. If we look at the question within our data of hip arthroscopy versus no hip arthroscopy, the trends, if anything, favor no arthroscopy. A couple point difference, not significant, but certainly not a major benefit of arthroscopy. What about the RCT? We have a great level 1 evidence now in overall dysplasia. This was presented earlier, so large randomized trial that was a major undertaking and gives us good data to learn from. The results currently are at 2 years. That certainly this will be critical to know what happens at 5 years because some of the problems may pop up down the line. But at 2.3 years, no difference in PROs. No difference in rates of subsequent arthroscopy, 4% in isolated PAO, somewhat consistent with the literature, and then 1% early reoperation, even if you had a scope, probably for those adhesion issues. So does this apply to borderline? So we can then look, the mean lateral centerage in that study is 18, so about 40% of these hips are probably borderline, but hopefully over time we'll get more high-level evidence in this group. So when does adding hip arthroscopy make sense? I think the challenge in borderline is we're not looking for one answer. We're looking for patient-specific answers that help us to pick different options in different patients. So in borderline, the labrum is often not the pain driver. It is can be unloaded with bony correction. Capsular management, including plication, I think we really don't know. It's hard to isolate the effect of those treatments compared to everything else going on in hip arthroscopy. So when do I think of adding arthroscopy? This is an evolving topic. So if there's major labral pathology on MRI or major associated FAI, that can be major CAM or major retroversion, those hips are going to have more significant cartilage or labral damage. And I think a diagnostic injection is a very useful proxy for what's going on in the joint versus out of the joint, that if they get relief with a diagnostic injection, I'm more likely to think the labrum's driving a fair amount of that problem. When we do arthroscopy, it needs to be targeted, so you want to do this efficiently and not cause a major hit like the one we saw earlier. So getting in and out quickly is important. You can do limited capsulotomies if you're just fixing the labrum. You probably don't need to be super aggressive with capsular management if you're doing a PAO as well, and want to avoid extensive surgical times. So the combined procedure we've shown in a single setting, an efficient arthroscopy, and then the PAO without staging is safe and effective, so 3% rate of complications. This is WashU and Mayo data combined. So ultimately, in the borderline, we're really looking to see the signals through the noise, that it all looks like sort of a mess, but as we get more understanding of the key factors, hopefully someday we have different clusters that we can guide to different treatment algorithms to really determine the optimal treatment. We've done some work in St. Louis developing a borderline hip instability score, so this takes in key factors that drove decision making, and we found 4 factors really drive this. Acetabular inclination may be the most important. Interestingly, we've found that to be better than fear. It's a major part of the fear index, but inclination alone, I think, is driving a lot of the effect of fear. Anterior center edge angle, the alpha angle, and an internal rotation and flexion. So we took those factors, and in a multivariate model, you can develop an electronic nomogram that the score is 0 to 100. The typical borderline hip is 50. Higher scores more unstable, lower scores less unstable. And you sort of get a bell-shaped distribution as shown on the right. When we looked at this now out at 5 years, 131 hips at 5-year outcome in St. Louis. In the higher instability group, a borderline score above 50, we saw significantly better outcomes with PAO. 12-point difference in Harris hip score, almost 30% difference in PAS score. So dramatic differences in those unstable hips. That's, again, about half of this overall group. We've then spun this off into a multi-center study called Orbit that is through Anchor, 23 surgeons enrolling over the course of several years, now have over 1,000 hips with low-dose CT, modern data including Baton score, and they're about 60% arthroscopy and 40% PAO. In the classic patient, a female with 20 to 25 lateral center edge, it's really almost perfectly even what people are doing, at least within our Anchor group in those hips. So hopefully over time we'll see better results. We have now 6-month outcomes, and at 6 months we have about 50-50 breakdown of arthroscopy or no arthroscopy if you're doing a PAO, and at 6 months no major difference as well. So we'll have better data on this over time. So in summary, hip arthroscopy is an attractive addition to a PAO in the setting of borderline, but we really need to be aware of the potential negatives of doing it as well. And if you're doing hip arthroscopy, really do it in a targeted way to minimize the potential negatives. And with the RCT, with large multi-center studies, the good news, I think, is we have better and better evidence coming in the future. And a quick plug, if anybody has interested residents or fellows, we'll be in St. Louis in a couple weeks for our St. Louis and Anchor HIPS course. If anybody has trainees interested in coming down, a great opportunity. Thank you.
All right, up next we have Dr. Westerman talking about concomitant or stage